The following podcast is part of a certified educational activity titled Applying Therapeutic Innovations Against ALL. From updated evidence to everyday practice. Access the entire activity and complete the post-test at peerview.com/DGJ860. Downloadable slides are also available.
Hello and welcome to Applying Therapeutic Innovation Against ALL. I'm Dr. Luke Maese from the Huntsman Cancer Institute at the University of Utah and Primary Children's Hospital here in beautiful Salt Lake City, Utah. And today we're going to explore some developments that have or will have implications for the management of our patients of all ages, pediatric, adolescent, young adult, and adults with acute lymphoblastic leukemia. So the evidence we're going to share was presented at recent medical congresses, which include the American Society of Clinical Oncology, the ASCO 22 annual meeting, and the European Hematology Association, or EHA 2022 annual meeting. And so throughout the presentation, I'll provide some practical points on the new evidence from both ASCO and EHA. Periodically, we'll also share some resources that summarize important take-homes from the evidence that we'll present. And so please take a moment to download these practice tools before we get started. So all right, with that, let's begin. So as we know, if you've taken care enough of patients with acute lymphoblastic leukemia, you're familiar with the key developments that have happened over the past half century. And some of these are very seminal, and we've tried to highlight them for you all today. Starting in the mid-60s, we were able to use combination chemotherapy with CNS-directed therapy, and we're able to cure approximately 50% of patients. Moving into the 1970s and 80s is when we were able to introduce asparaginase products into both pediatric and adult ALL regimens. We showed that high-dose asparaginase does improve outcomes. And then into the 21st century, we see that newer agents are continuing to come about. So dasatinib, which is a tyrosine kinase inhibitor, was approved in Ph-positive ALL. Pegylated asparaginase was approved as well in 2007 in the front line for patients with acute lymphoblastic leukemia. And for those patients who have hypersensitivity reactions, in 2011, Erwinia asparaginase substitution was approved for patients with ALL who have this complication develop. Moving forward then into the 2010s, 20-teens, imatinib was approved in Ph-positive ALL. We have blinatumomab, which we'll be discussing in one of the key abstracts that was reported at ASCO and EHA. This was approved in relapsed refractory B-ALL. Ponatinib, which is another tyrosine kinase inhibitor, was approved in Ph-positive ALL in patients with this common T315I mutation that can make patients resistant to TKIs themselves. And again, this is something we'll review in one of the abstracts coming up. Blinatumomab was approved for MRD-positive disease in 2017, and then inotuzumab, another antibody, was also approved in 2017. Tisangenlecleucel, which was really a game changer for patients with relapsed refractory disease, got a lot of coverage in the mainstream media. This was approved in 2017 for patients with relapsed refractory disease. And then looking at T-cell ALL, a less common type of acute lymphoblastic leukemia, nelarabine was approved in relapsed disease in 2018 for these patients, and has now actually been moved into the upfront treatment for patients based on the COG ALL 0434 study. And then the most recent asparaginase product, long-acting product, I should say, to be approved was calaspargase pegol in children and young adults. And then now, just looking at last year, brexucabtagene autoleucel was approved in patients with relapsed refractory ALL in adult patients, and then the newest asparaginase product, recombinant Erwinia asparaginase, was most recently approved in late June of 2021 in the setting of hypersensitivity to E. coli-derived asparaginase. So with those key developments, of course, we've developed or shown great successes, but challenges do remain in this patient population, and it behooves us to continue to move this needle forward. And some of these abstracts that we'll talk about some of these topics. But of course, we've seen improved results of first-line therapy for all age groups. We know intensive chemotherapy is essential for cure, but we have to consider what are the side effects of these things, both long and short term. The acute toxicities can be limiting depending on the ages of the patients as well. What about resistance? Resistance to the medicines that we're using can come about, and so we need to have newer medications that we can provide patients, especially in the relapse refractory disease setting. And so we need to optimize the use of our standard chemotherapy compounds in adults and adolescents and young adults for that matter. And these new targeted compounds with different mechanisms of action allow us to do some of this. And now we're challenging these traditional treatment paradigms, as we'll see with some of these abstracts and where we can use these newer medications. As we think about some of the challenges specifically as it relates to one of the compounds we talked about in the timeline, asparaginase, we have recently seen the impact of discontinuing a medication that we know is important for patients with this disease. And this here evidence demonstrated by Sumit Gupta and colleagues from the Children's Oncology Group ALL Committee that looked at the effect of discontinuing this drug in patients with high-risk acute lymphoblastic leukemia, pediatric patients, I should say. And what they saw is that, in those patients who weren't able to receive their prescribed asparaginase courses, there was an increased risk of an event by 50% among this group of patients. And looking at the Kaplan-Meier curve, you can see in the dashed orange line that these patients who didn't receive their asparaginase doses had a significantly inferior disease-free survival, as opposed to those patients who completed either their prescribed long-acting courses or were able to complete their prescribed courses with Erwinia. So now we'll get into some of the themes from the abstracts that we've selected to review with you today from ASCO and EHA. And we'll first start with asparaginase itself and what can we learn from what was presented recently at ASCO and what's out there now that's new for patients. And if you're treating patients with ALL, you are familiar with the approved asparaginase preparations. In the first two columns, we have peg-asparagase and cal-asparagase peg-al. These are the long-acting products that are E. coli derived products that are used in the first line for patients who have ALL with the approved dosing included there. Of note, cal-asparagase is not approved in patients who are older than 21 years of age. And then if you look to the second two columns there, Erwinia asparaginase and recombinant Erwinia asparaginase. These products are short-acting products, as you can see with their half-lives displayed there for you all. The dosing as well is there, and what I will point out for the recombinant Erwinia, currently the approval is for 25 milligrams per meter squared on an every 48-hour basis. However, there are additional dosing regimens under investigation, and we will talk about that in just a little bit. So looking at the standard management of hypersensitivity reactions with primary E. coli derived asparaginase products, we encounter these in patients to a degree that's not actually rare. So about 10 to 15% of patients will have a hypersensitivity reaction to a first-line product. This includes anaphylaxis, allergy, but also some immune destruction with neutralizing antibodies. You can also more rarely have silent inactivation, so inactivation of the actual asparaginase molecule without signs of hypersensitivity. We think this is rare, but we're just starting to study this more and more, so we'll see, especially in the light of pre-medication for patients, that's becoming more and more used throughout the treatment of this disease. But for these hypersensitivity reactions, we know that the asparaginase is often interrupted. We have to give treatments for acute anaphylaxis, and this includes antihistamines, glucocorticoids, Tylenol if needed, acetaminophen, and epinephrine in those serious cases. And then it's called to switch to Erwinia which is an alternatively derived product, and most patients who have hypersensitivity to an E. coli derived product will tolerate this Erwinia product. But in the case of a diagnosed inactivation, the standard next step, as we said, is to switch to Erwinia, and unfortunately shortages of these medications over the past 7 to 10 years have led to alternative practices which include desensitization, but ultimately this has led to the development of a new medication that's Erwinia derived, but using a recombinant production process. And we'll talk about this new medication now, and this is recombinant chrysanthespase or recombinant Erwinia, also known as JZP458. It's produced in a Pseudomonas fluorescens background, and it's non-E. coli derived. It's very similar to Erwinia asparaginase in its amino acid sequence, and it has been now approved for use as a component of multi-agent chemotherapeutic backbone for the treatment of patients with ALL and lymphoblastic lymphoma in adult and pediatrics who have developed hypersensitivity to an E. coli derived product. And so recently, which was presented by Maese and colleagues at the ASCO 2022 meeting, was the phase 2/3 trial of a recombinant Erwinia asparaginase in patients with ALL and lymphoblastic lymphoma. And these patients who were eligible had to have a grade 3 or greater allergic reaction or silent inactivation. It included 2 parts, which looked at the intramuscular route of administration and the intravenous route of administration. The abstract focused only on the intramuscular route, but these patients received 6 doses of JZP458 on a Monday, Wednesday, Friday schedule, and the duration of treatment depended on how much was remaining in their treatment schedule. It was a pharmacokinetic study and included many different time points, 8 total in the first course of treatment, and several other PK collection time points in subsequent courses of treatment. And what they reported was a high proportion of patients were able to achieve the target nadir serum asparaginase activity level, which was greater than or equal to 0.1 at both the 48 and 72-hour time points in patients who received 25 milligrams per meter squared on Monday, Wednesday, and 50 milligrams per meter squared on Friday. As you see here in the bar graph, you see the different cohorts that were enrolled at the different doses, purple being the last 48-hour time point, and yellow being the last 72-hour time point. The focus of the report at ASCO was on this cohort 1C, and as you're reviewing this, that is the one to focus on. Of course, asparaginase has adverse events, and we'll talk about these with each of the abstracts we discuss. The rate of treatment-related adverse reaction was not surprising. It was consistent with other asparaginase products. Of note, the events that led to discontinuation are the ones that really are the ones that we're primarily focused on, and you see pancreatitis and hypersensitivity to this product leading to discontinuation in some patients. But from a hepatobiliary standpoint, this was a quietly well-tolerated medication. So take-homes from that abstract included that this drug is currently approved, as we said, at a 25 milligrams per meter squared dose every 48 hours. The focus of this abstract was to call attention to the differential dosing of cohort 1C, which included 25 milligrams per meter squared on Monday, Wednesday, and 50 on Friday. And they did show adequate serum asparaginase activity at both 48 and 72 hours with this cohort. The safety profile was consistent with the published literature on asparaginase products. And this updated data from all the patients that were included on the trial has been submitted to the FDA to support a label update, and this should be shortly coming. When we think about the practical applications of asparaginase and how this affects our practice in patients, we can look, for example, at a patient, a 16-year-old with pH-negative BALL who has a reaction to PEG asparagase during consolidation, and we know we need to switch to Erwinia-derived product. If we're using recombinant Erwinia, then what dosing strategies should we think about? As we mentioned, this is FDA approved at the 25 milligrams per meter squared dose every 48 hours. But sometimes this isn't feasible for all centers completing this dosing on a Saturday or Sunday. And then it comes into question, can you work this out with your nursing staff, with your inpatient staff if you don't have clinic weekend hours? And so recognizing this, this is why this data that is reported is so important. This 25, 50 milligrams per meter squared dosing allows for adequate 72-hour depletion, so you do not need to dose on the weekends. However, again, working this out with families and understanding, that this is a higher dose. The trial did show equivalent side effects at all doses, so it seems to be safe, and it hasn't been updated yet in the label, but something that centers are considering when they're thinking about a situation like this. And so as we look now, turning our attention to CAR T cell therapy and what was reported recently at ASCO and EHA in the treatment of pediatric and adult ALL, we know that in previous reports, these products are incredibly effective, especially in a multiple relapsed refractory patient population. These are the major studies that have had the most, or some of the most accrual. The Linea study, which looked at Tecengen-Leclucel, and then the Zuma 3 and 4 studies, which looked at Brexucel. And you see here the efficacy was seen, early on, and of course accompanying toxicity in these patients, which includes cytokine release syndrome, neurological side effects, was noted. But still, again, this is a multiply refractory, relapse refractory population. So these toxicities are, for the most part, tolerable. And so what happened at the annual meetings this year at EHA, they updated the Linea trial and were able to show sustained long-term benefits in patients with minimal late side effects. And so they had a greater than 5-year follow-up study of this population of patients, which included 97 patients that were enrolled, and 79 of these patients received drug. And the overall response rate was 82%, and the 5-year relapse-free survival rate was 49%. The median relapse-free survival was not reached. I think reviewing this in a little bit closer, with a little bit closer eyes, the probability of B-cell aplasia at 6 and 12 months was 83 and 71%. This is something we're watching for in this population, as when they recover their B-cells, there's concern that their disease can recur as well. ASCO, they updated the Zuma 3 trial, which looked at Brexucel's efficacy in adult ALL, and again, showing some very impressive numbers here, with on the left the overall survival in phase 2 treated patients, and on the right the pool phase 1 and 2 treated patients, and looking at all of these patients together, the median overall survival was over 25 months, and was actually not reached in the phase 2 patients who achieved complete response. So again, some impressive numbers for a very difficult population of patients. Practically looking at how we think about CAR T cell therapy and its complications, there are these now 2 CAR T constructs that are approved in ALL. There are societies that have published guidelines on how to think about this therapy. If you use an example of a patient who had relapsed refractory ALL, B-cell ALL, with third relapse, of course, CD19 positive, a patient, you think about the complications that could happen, which include infection. We talked about the neurological toxicities. We talked about how these patients can have lots of side effects, and this can be something to consider. And so looking at these things that can happen, reviewing the recommendations from these societies is important, and seeing how you can ameliorate some of these side effects. Do you have to wait a little bit longer to infuse? Do you have to bridge them with something other than CAR T to get them past this point? Something to be mindful of. So as we move then now to our third subject, the chemo-sparing options, and again, we talked about these more targeted agents in a particular set of population of patients for improving outcomes and decreasing toxicity. when we think about these targeted agents, tyrosine kinase inhibitors are some of the first ones that come to mind, especially in pH positive ALL disease. And then we also look at chemotherapy sparing options, and this includes blinatumomab, which we briefly mentioned on the timeline. We know that these agents are effective in patients with pH positive disease, these tyrosine kinase inhibitors. We know that blinatumomab is an effective therapy in relapse refractory disease. And so some of the investigations that were reported at ASCO and EHA, this included a phase 2 study that assessed the chemo-free combination of ponatinib, which is a third-generation tyrosine kinase inhibitor, which has been investigated for some years now, and blinatumomab in adults with newly diagnosed pH-positive ALL and relapse refractory pH-positive ALL or CML with lymphoid blast phase crisis. And you see here the protocol that was done in this phase 2 study with ponatinib up front, along with blinatumomab over the first month, and then a consolidation phase again with blinatumomab and ponatinib, and then a maintenance phase with ponatinib. What was reported at both ASCO and EHA is that this is a highly active combination of drugs in newly diagnosed and relapse refractory positive patients. You see the extremely high CR/CRI rate in the front line, almost 100%, and even in above 90% in the relapse refractory population as well. Turning to looking at the molecular response, you see some very impressive numbers with complete molecular response, over 80% and just about 80% in the relapse refractory population, and in major molecular remission or response, I should say, almost getting to 100% again in the front line, and nearly 90% in relapse refractory patients. So again, these targeted therapies together showing great activity, and then looking at the survival rates in the newly diagnosed patients, over 90% of patients were alive 2 years after. In the relapse refractory patients, over 60%. And again, this is a typical disease that you would think would carry much lower survival rates, and you're seeing much improvement with these two targeted agents. And so again, as we talked about, these new compounds do have their toxicities as well, but these two agents together really showed a very favorable toxicity profile, especially when you compare it to myelosuppressive chemotherapy, and really the major side effects which are known with ponatinib were thrombotic complications, which included a stroke and a deep vein thrombosis. Blinatumomab has neurotoxicities, but these are typically tolerated pretty well. There was one patient who had to discontinue because of a tremor with blinatumomab. And so in summary, of course, further study is needed. These numbers aren't huge, but they are significant, and you did see significant responses that were demonstrated in these reports that show this combination is highly active in this newly diagnosed and relapse refractory population. If we're getting these types of survival numbers at 2 years, it behooves us to think about transplant, as transplant was thought to be necessary in this population, but maybe not so in this newly diagnosed population with this combination. Time will tell. And then again, the safety is consistent with prior experience with these agents. For practical applications of this regimen, again, I think it's understanding the unique safety profiles of these new agents is important. We're used to kind of classic myelosuppressive chemotherapeutic complications, and these, while they can be suppressive to the bone marrow, isn't necessarily the major thing to think about. And with ponatinib, these thrombotic events are something to note. There are also cardiovascular complications that should be monitored for closely. And then with blinatumomab, while this is a medication that we now had about a decade of experience using, people are familiar with it, and in past cases early on, we're using it in a very in a population of patients who have lots of disease burden, and you see more CRS or cytokine release syndrome we're not seeing that as much anymore. But if we are using it in newly diagnosed population, it's something to be mindful of, and have an experienced nursing staff to help you manage these things. Neurotoxicity is something that some patients we know will have, but again, watching out for these and being mindful of this side effect, you can usually subdue it and get past this, and it rarely leads to discontinuation of medication. So that concludes our exploration of the noteworthy recent evidence in ALL as reported at the ASCO and EHA meetings. I hope you found this activity informative and useful for your practice. Thank you all for joining us.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/DGJ860. This program is supported by an independent medical education grant from Jazz Pharmaceuticals.